invite Dave Dawson, our course chairman, to come back and speak to us again. He's going to talk to us about aneurysms involving the renal and visceral arteries. Dave.
We're going to shift from something that's new and exciting to something that is a little bit old school, and that's aneurysm treatment. A lot of the data we have about visceral artery aneurysms are old data, and we're trying to put into perspective the natural history of these problems, combining some of the historic data and what we see in the textbooks with what we see now based on the available imaging studies. I have no conflicts relevant to this presentation. I'll start with a case presentation and then talk a little bit about renal artery aneurysms, splanchnic artery aneurysms, or aneurysms of the arteries to the viscera. I'll talk about it as a group and focus a little bit on the most common type of splanchnic artery aneurysm, the splenic artery aneurysm, and talk about treatment considerations. So this is a 53-year-old man who was referred from a rural area. He's a lumber mill worker. He had a back injury on the job and had some pain, and that resulted in an imaging study being performed. And you can see here that in the right upper quadrant, there's the world's biggest gallstone. So he had plain films and a CT scan for the workup, and what was found is actually a calcified renal artery aneurysm. He had normal renal function. His serum creatinine was 1 milligram per deciliter, and his blood pressure was in the normal range, 132/83. CT scan showed this what looks like a rim-enhancing lesion. Of course, that's just a calcification within the aneurysm wall in the renal artery. It's difficult to look at these with just the axial or the orthogonal views. And so to better evaluate visceral artery aneurysms, multiplanar reconstructions and thin slices and thicker slabs I think are very useful. And this is a thin client version of TerraRecon that can be used on any networked computer to further evaluate the aneurysm. And you can create a 3D volume rendered version of that and rotate it and look at it from different perspectives. And by doing that, you can tell that this is a densely calcified aneurysm. It's almost spherical. It's a saccular aneurysm, and it's located right where the renal artery trifurcates. So it's not on the main renal artery. It's right at the branch points. The patient, prior to referral, had been evaluated with a diagnostic arteriogram. And the CT images that you saw were sent with the patient and post-processed in the clinic. The diagnostic arteriogram that was done prior to the referral was not followed with embolization or treatment because of a concern that embolization couldn't be done without occluding the renal artery, and that a covered stent wouldn't be an option because of the location at the branch point. Duplex scanning was performed, and you can see that the aneurysm measures about 2.8 centimeters by ultrasound and by CT. The duplex has the advantage of also giving us physiologic information about flow characteristics in the renal artery adjacent to the aneurysm. This is a selective arteriogram done. You can see the calcified rim on the subtracted images. You can see that the aneurysm arises right at this point, where the three main renal artery branches come off. And it was elected to treat this with an embolization technique. First step was to selectively engage the renal artery, and a hydrophilic wire was advanced past the aneurysm. That was then exchanged with a catheter for a stiffer 35 thousandths Rosen wire, and with the wire in place, a flexible sheath could be tracked into the renal artery. And so now we've got a 6-French sheath in place. I elected to do this with a buddy wire technique. The 18,000 guide wire went past the renal artery origin, so that if in the process of embolizing the renal artery aneurysm there was encroachment on the main renal artery, there would be the opportunity to stent. This is a microcatheter system engaging into the renal artery, and with the microcatheter in the renal artery aneurysm, a framing coil was placed. And this is basically a 3D spherical construct to build a big ball inside the aneurysm. This is a cage that can then subsequently hold smaller coils. So this just shows a little bit about this particular system. The system used was an 18,000th framing coil. It's a detachable system, so it's on the end of the wire that advances it through the microcatheter, but it forms loops that then orient themselves in 3 different planes. The device has a little electrical system that detaches it from the end of the deployment system when you're ready to separate it. And then with the framing coils in place, additional coils can be placed. In this situation, a hydrocoil was used, and the hydrocoils are a coil that includes a polymer on the outer surface of the coil that swells when it's in the blood. To increase the diameter and the bulk associated with that, it provides for additional filling of the space. So with a couple of framing coils in place and a number of hydrocoils placed within it, the aneurysm is fairly densely packed. In follow-up imaging, you can see that there's a substantial artifact on the CT associated with the metal, and it's a little bit difficult to see whether or not there is or is not flow, but duplex scanning was useful to show that there was no flow within the aneurysm at the hilum of the kidney. Now, renal artery aneurysms are rare. Angiographic prevalence is less than 1% in the general population, and in those with hypertension, 2.5%. More commonly, they're found in patients with fibromuscular dysplasia. Aneurysms usually involve the main renal artery and its bifurcation. Calcification of renal artery aneurysms is often apparent, and you can see this on a plain film in patients with renal artery aneurysms in about a quarter to a half of patients. Most renal artery aneurysms are true aneurysms, and they can be associated with atherosclerotic disease or the most common degenerative aneurysm in visceral segments. But fibromuscular dysplasia, actually fibromuscular dysplasia is the most common associated condition associated with true aneurysms. These involve typically the distal portions of the main renal artery or the point of division. False aneurysms or pseudoaneurysms may be complications of invasive procedures in the kidney, such as a biopsy or nephrostomy. So branch arteries are injured within the parenchyma, and false aneurysms are formed. These have intraparenchymal location. Aneurysms can also be classified by their morphology as saccular or sac-shaped, fusiform, or a football-shaped dilatation. They can be associated with dissection and subsequent dilatation or intrarenal microaneurysms. Symptoms occur only in the minority of patients. The patient that I presented had symptoms of back pain, but he had musculoskeletal back pain, and most patients don't have pain specifically associated with the symptoms. Hypertension can occur. Sometimes patients, of course, have underlying essential hypertension, but if there is compression of a renal artery branch by the aneurysm, that can result in renal vascular hypertension. Or in patients who have microembolization of thrombus, there may be parenchymal damage and hypertension as a result of that. In those patients with embolization, they may present with hematuria, or there may be, in rare cases, abdominal pain associated with expansion of the aneurysm or embolization. There can be decline in renal function, or if a patient presents with a rupture, acute hemodynamic collapse. Renal artery aneurysm rupture is rare. It's reported in less than 10% of patients with renal artery aneurysms, and it's difficult to know exactly what prompts renal artery aneurysm rupture, but it's been associated with an aneurysm size of greater than 2 centimeters and more common in pregnant women. These are patients with fibromuscular dysplasia. The mortality risk of a renal artery aneurysm rupture is thought to be less than 10%, but the mortality of pregnancy is higher, and maternal mortality up to 50%, and fetal mortality in the majority of cases. The indications for treatment, therefore, are symptomatic aneurysms, or those over the 2 centimeter size threshold, aneurysms that are enlarging on serial imaging, or aneurysms in women who are pregnant or anticipate pregnancy. Of course, ruptured aneurysms needed to be treated, and all false aneurysms should be treated, and also aneurysms associated with arteriovenous fistula or dissection, often an iatrogenic complication, should be treated. The options for treatment include both surgical and endovascular techniques. The surgical treatment can be aneurysmorrhaphy or surgical removal of the aneurysm and repair of the artery, either a primary repair or more commonly a vein patch angioplasty. The distal location of the aneurysm in many cases makes that a difficult operation without removing the kidney and repairing the kidney on the back bench, an ex vivo repair. Because of this, in many cases, the surgical treatment historically for many patients has been a nephrectomy. There are a variety of endovascular techniques. We'll talk about those a little bit towards the end. Splanchnic artery aneurysms include splenic artery aneurysms, the most common, aneurysms of the hepatic artery or superior mesenteric artery, and less commonly, celiac artery, gastric, and gastroepiploic arteries, aneurysms of the branches of the SMA, the jejunal, ileal, and colic arteries, and also gastroduodenal, pancreaticoduodenal, and pancreatic arteries. One of these in particular, celiac artery aneurysm, I think we're seeing more frequently now diagnosed as really a poststenotic dilatation in patients who have proximal compression of the celiac artery. When rupture occurs, it causes intra-abdominal or either retroperitoneal or intraperitoneal hemorrhage. Patients present with acute abdomen and shock. It's not uncommon for the patients to have a history of some pain and perhaps some symptoms of hypotension with initial stabilization if there's a contained retroperitoneal rupture or splenic artery aneurysm rupturing in the lesser sac, and then a secondary collapse. That secondary collapse can be catastrophic as there's then free rupture. It's difficult to find the source of bleeding with these cases. I've seen very few of these, but the general findings are you operate on a patient with hemodynamic collapse, there's a large retroperitoneal hematoma, and digging through that is really a very unpleasant thing to do. And so you have to have some kind of imaging to be able to find the source of bleeding, and that can include intraoperative duplex scanning or angiography intraoperatively or immediately postoperatively. The prevalence estimates vary. There is a higher reported mortality in the older literature. So when I looked at a copy of Rutherford's textbook of vascular surgery from about 2 editions prior, it talked about celiac artery aneurysms being occurring in only 200 patients reported in the literature, and these were a highly mortal condition, and they should be operated on whenever found. And I've probably seen within the last year, Bill, maybe 5 or so incidental findings of less than 2 centimeters celiac artery aneurysms on imaging studies. And so that would suggest that they're much more common than the older studies had reported, and we don't really see good prevalence estimates in the modern literature, but we know from experience that they're common findings on imaging studies. The natural history is uncertain. It depends on which artery is involved, what the pathology is. Is this an atherosclerotic or degenerative aneurysm? Is it associated with fibromuscular dysplasia? Is it in a young woman who might be pregnant? Is it in a 70-year-old person with a calcific aneurysm? What's the morphology, shape, calcification of the aneurysm and coexistent disease? The distribution of these is shown here. The splenic artery represents about 60% of the splanchnic artery aneurysms, hepatic 20%, superior mesenteric artery about 5%, and celiac just under 5%. These are where most of these splanchnic artery aneurysms occur. A variety of imaging techniques can be used, including duplex, CT, and angiography. Splenic artery aneurysms, as I said, are the most common visceral artery aneurysms, representing 60% or more of the splanchnic or visceral artery aneurysms. There is a female-to-male predilection, 4-to-1, and the contributing factors for the development of splenic artery aneurysms include fibromuscular dysplasia, the medial fibrodysplasia type. It's also been associated with pregnancy and in particular multiparous women, and it's associated with portal hypertension, cirrhosis, and that's also a rupture risk. Pseudoaneurysms may form in the splenic artery from inflammatory conditions, infection, or pancreatitis, where the splenic artery is adjacent to that retroperitoneal organ. The imaging findings for splenic artery aneurysms, they are often well-defined and homogeneous on a contrast-enhanced CT, fairly easy to discern. There is a variable location along the course of the splenic artery. The aneurysms, the true aneurysms associated with fibromuscular dysplasia are often found in the more distal course of the vessel, and mural thrombus may be present. The the significance that mural thrombus has not been defined. Peripheral calcification is common, and a signet ring appearance is the typical appearance on plain film. So around calcific signet ring calcification on the left upper quadrant on a plain film, especially on an older individual, is most likely a splenic artery aneurysm. Indication for treatment of splenic artery aneurysms, well, certainly symptomatic aneurysms. Size is a little bit variable. What's been recommended, some series have suggested anything over 2, others monitoring up to 3. But certainly aneurysms less than 2 centimeters in a postmenopausal individual or older person probably can be safely watched. Enlarging aneurysms, or those in women who are pregnant or have childbearing potential, should be dealt with. Of course, those with rupture, false aneurysms. And for patients who have portal hypertension, in particular those who are expected to undergo or may undergo liver transplantation, there should be elective repair, as liver transplantation has been associated with a risk of rupture. In pregnancy, most splenic artery aneurysm ruptures occur in the 2nd and 3rd trimester, as I mentioned. They are more common in women who have had multiple pregnancies. And if they're found during pregnancy, repair should be considered because of the significant risk of rupture and the risk of both fetal and maternal mortality. Older series suggested that there was a very common fetal loss and greater than 50% maternal mortality. More recent series have shown better results. There are a variety of surgical options for treatment of splenic artery aneurysms, either open or laparoscopic procedures. The aneurysms can be excised. Interposition grafting is typically not required, as the spleen is often able to remain viable based on the blood supply from the short gastrix. The aneurysms can be ligated or clipped, and this can be done laparoscopically. Or if the aneurysm is very distal in the splenic artery, it may be removed in combination with splenectomy. In general, arterial reconstruction is not indicated, and if there is splenic infarction associated with ligation, it's usually tolerated. It's rare that there is a need for splenectomy for necrosis or abscess of the spleen. But it's not uncommon for patients to have a post-embolization or post-ligation syndrome with transient pain, fever, and leukocytosis. Endovascular techniques for treatment of visceral artery aneurysms include covered stents. They're both balloon expandable and self-expanding covered stents that can be used for treatment of visceral artery aneurysms. I gave a case presentation at the beginning that showed an example of embolization. And embolization can be done with arterial occlusion, so a splenic artery aneurysm can be treated with occlusion of the splenic artery, but in the case of the renal artery aneurysm, embolization with maintenance of patency of the vessel. The embolization can use coils, detachable coils, plugs, or a stent-assisted coil embolization where a stent is placed to maintain patency of the vessel, and the interstices are catheterized, and then the aneurysm is embolized. So to summarize, for visceral artery aneurysms, splanchnic artery aneurysms, splenic arteries are the most common location for these, and most are benign incidental findings, but not in pregnant women. Small atherosclerotic or degenerative aneurysms less than 2 centimeters are often monitored, as there is a risk associated with doing something to treat them, and these small aneurysms seem to be associated with a very low risk of rupture. But pseudoaneurysms occurring in the splenic, hepatic, or mesenteric arteries should be treated primarily because of the different natural history of these aneurysms, often associated with an inflammatory or infectious process. Thank you very much. Scan for the workup, and what was found is actually a calcified renal artery aneurysm. He had normal renal function. His serum creatinine was 1 milligram per deciliter, and his blood pressure was in the normal range, 132/83. CT scan showed this what looks like a rim enhancing lesion. Of course, that's just a calcification within the aneurysm wall, based on the available imaging studies. I have no conflicts relevant to this presentation. I'll start with a case presentation and then talk a little bit about renal artery aneurysms, splanchnic artery aneurysms, or aneurysms of the arteries to the viscera. I'll talk about it as a group and focus a little bit on the most common.
We're going to invite Dave Dawson, our course chairman, to come back and speak to us again. He's going to talk to us about aneurysms involving the renal and visceral arteries. Dave.
We're going to shift from something that's new and exciting to something that is a little bit old school, and that's aneurysm treatment. A lot of the data we have about visceral artery aneurysms are old data, and we're trying to put into perspective the natural history of these problems, combining some of the historic data and what we see in the textbooks with what we see now based on the type of splanchnic artery aneurysm, the splenic artery aneurysm, and talk about treatment considerations. So this is a 53-year-old man who was referred from a rural area. He's a lumber mill worker. He had a back injury on the job and had some pain, and that resulted in an imaging study being performed. And you can see here that in the right upper quadrant, there's the world's biggest gallstone. So he had plain films and a CT scan.